Next, we're going to talk about the skeletal system. So the head is approximately 1/4 of the total body length. We're just going to go through these different terms related to the head. Molding. We talked about molding during labor and delivery when we were doing that unit. That's the shaping of the fetal head by overlapping of the cranial bones during birth. You can see in the picture here, in A shows molding, and then B, A and B show molding of the head. Next, we'll talk about the spine. It has a forward concave curvature, so it has two curves. It has one, towards the bottom of the spine, the infant's bottom, and then one the thoracic curve. So it's a forward concave curvature, both of those. Vertebrae should be straight and flat. If there's a pilonidal dimple with hair, this can be associated with spina bifida. And what this is, you should just Google spina bifida or the pilonidal dimple and kind of see a picture of it. It's hard to describe without seeing a picture, but it's one of the things you assess for down in the sacral area of the infant. And if that's present, you have to worry about is there something internally going on with the spine that didn't develop correctly. The extremities, developmental dysplasia of the hips, also DDH, is the instability of the hip, where the femoral heads are displaced from the acetabulum. You want to look in your book on page 523. There's a figure 23-12, and that does a really good job of explaining how the provider, nurses usually do not assess for this. It's usually a physician or a nurse practitioner, but how they assess for hip dysplasia. So be sure and be familiar with that on page 539 in your book. That's figure 39-12. Next are signs of skeletal problems. We skipped over extremities. So with extremities, you can have extra digits, missing digits, and fused digits, and that's what the polydactyly, oligodactyly, and syndactyly. So with the oligo, you're missing digits, whether it's your hands or your feet, toes and fingers. Poly, you have extra fingers or toes, and then syndactyly, you have your fingers or your toes are fused. So signs of skeletal problems: if you have a fractured clavicle, this is common if you have a macrosomic infant, so that's a large infant, or shoulder dystocia, a difficult birth. You can have unequal movement in the upper extremities, or crepitus over the clavicular area when you're palpating it and assessing the baby after birth. Club feet are when the foot turns inward and is fixed in a plantar flexion position. So I think you're familiar with what club foot would look like. One thing you can do to differentiate whether it's fetal positioning in the utero or club foot is to try to move the foot. If it stays fixed or you can't physically move it, and you know it's a bony problem, club foot. If you can move the foot into what we would consider a normal position, just know it's from fetal positioning in the utero, and it'll be fine. So this slide shows caput, cephalohematoma, and subgaleal hemorrhage. So let's talk about caput first, and that's picture A. With caput, you have generalized edematous area of the scalp on the occiput. It extends across the suture lines and disappears spontaneously within 3 to 4 days. It's common with vacuum delivery, and it's also common to be in combination to note that there's bruising along with the caput. So it's important that you know the difference between caput and cephalohematoma. And one of the differences are that it extends across the suture line. Okay? Next is cephalohematoma, and this is a collection of blood between the skull bone and the periosteum. It does not cross the suture line. It's firmer and more well-defined, and it usually resolves in 2 to 8 weeks. And these babies usually end up with hyperbilirubinemia because of this breakdown of this very large, essentially bruise, the collection of the red blood cells, and breaking those down. It's normal for those babies to have hyperbilirubinemia. So you can see the difference here in A, that the caput extends across sutures. It's more edematous and fluid. And over here, the cephalohematoma is a collection of blood vessels, and it does not cross the suture line. Okay, and then let's talk about the last one about the subgaleal hemorrhage. These are actually not very common, but it's bleeding in the subgaleal compartment. It's a result of a lot of traction and shearing forces on the scalp during delivery, so these are usually very rough delivery. Most common would be a vacuum delivery. The vessels are torn and bleeding can be severe. They can lose essentially a lot of their blood volume into the periosteum space. So as the nurse, you do serial head circumferences to measure it. And of course, if they're bleeding, the head circumference will continue to increase. And you also want to watch for signs and symptoms of hypovolemic shock, because they're losing a lot of blood. Even though they're not actively bleeding, they're essentially internally bleeding in their head. They will also have a decrease in their level of conscious, not necessarily related from the blood loss, but from pressure on the brain. And they'll also have a decrease in their hematocrit. Another thing, their ears, they can have a forward positioning of the infant ears related to where the bleeding is. But the subgaleal hemorrhage is not as common, but definitely be sure that you can differentiate between caput and cephalohematoma. Next is the neuromuscular system. So the neuromuscular system is almost completely developed at birth. The brain requires glucose and a significant amount of oxygen for adequate metabolism. So next it talks about normal tremors, tremors of jitteriness, of hypoglycemia, and seizure activity, and how you can differentiate those. And those are listed in the book, but I also just kind of summarized them and listed them in my notes pretty quickly. So if a baby is having tremors and jitteriness, that's easily elicited from any kind of motions or noise. So like if you elicit the Moro reflex by noise, and so if they're jittering, if you notice they've got mild tremors and they're jittering, if you take and hold their hand or hold their leg, so in my notes you'll see when it says gently restrain the body part, if it's tremors or jitterness from hypoglycemia, that will stop. However, if it's a seizure, when you gently hold it and try to restrain it, it will continue. So that's one way you can tell if the baby is jittery or having a seizure. If it is tremors, if it's jitteriness, when you do passive flexion or reposition that extremity, that movement stops. If it was a seizure, it would continue. And also note that seizure activity is associated with ocular and autonomic changes, so where jitteriness is not. The newborn reflexes are listed, begin on page 541, and there's, I think, about 3 or 4 pages here in this purple table that go through the normal newborn reflexes. I also posted a video on normal newborn reflexes. You'll need to be familiar with these. I hope you've been able to see these in clinical when you've been doing your newborn assessment, whether it's with your nurse or your clinical instructor, but where you could actually go through all of the different normal newborn reflexes. But be familiar with them, and I also posted a video because those are easier to read in the book and follow the video than me to try to lecture on a video and not be able to demonstrate those. now we're going to talk about the different behavioral characteristics and the sleep-wake states. So other factors that influence the behavior of newborns include their gestational age. So preterm infants show signs of fatigue much sooner than term infants. So here we're talking about the baby's sleep-wake cycles and their behavior characteristics and how it can be influenced by their gestational age. So preterm babies just tend to get more tired more quickly. As far as the time, it's the time since birth, the time since their previous feeding, and even the type of delay, the time of day that affects the baby's sleep-wake states. Different stimuli such as noise, light, and alarms, and even a tense mother. Babies can tell if their mother is tense, and they may have poor feedings related to that. And then as far as medications, mothers who got an epidural, those medications have been researched, and we know that they can affect breastfeeding. So this slide goes through the different the newborn sleep-wake states. In A, this baby is in a deep sleep. B, a light sleep. C is drowsy. D is a quiet alert. E, active alert. And F is crying. So the optimal state of arousal is the quiet awake, quiet alert state. And so that would be D. This is when the baby smiles, vocalizes, and really watches, kind of in tune with the parents. So that's the quiet alert state, which is D. Behaviors, infants can control their behaviors to maintain optimal arousal state. And so basically if they're being overstimulated or understimulated, the infant can adapt to that. Some of the things they can do is withdraw, push away with their hands and feet, turn their head or even fall asleep or get fussy and cry. So babies have a way of controlling their sleep-wake state, and of course as the baby matures they become better at this. Newborns sleep an average of 16 to 19 hours per day, and as the baby matures they gradually stay awake longer. So more behavioral characteristics, the sensory behaviors, the vision. Babies can see 8 to 12 inches away, and of course as the baby gets older they can see further away, but at birth they can see 8 to 12 inches. They prefer faces. They prefer black and white over color because they can't see color till they're about 3 months old. And they prefer complex patterns as opposed to simple patterns. So what you'll see in the NICU for preterm babies are black and white pictures of maybe a maze, but very complicated patterns, complicated pictures, or pictures of their family in their bassinets, because that's what they prefer. Hearing, they prefer their mother's high-pitched voice and her heartbeat. We'll talk about routine hearing screens later. Smell, they can smell their mother and they can smell her breast milk. As far as their taste, they have a preference to sweet. As far as touch, their face, hands, and feet are the most sensitive parts of their body.